Okay, wonderful. So thank you so much for inviting me to address the committee. I'm going to be talking sort of in wearing my hat as a fellowship director at Yale University, running our addiction medicine fellowship, but also talk about some of the work that we've done in the medical school and in the residency program, and thinking about ways that we might be able to disseminate these types of things moving forward. So we all know this is something that we've been talking about and struggling with today. Only 1 in 5 people with opioid use disorder actually receive treatment, leading to a substantial treatment gap. And just wanted to kind of talk about how this hits home for me. As I was on the train down here last night, I actually heard about a childhood friend who overdosed and died just recently. And I couldn't help but think, what made him not come into treatment? And certainly some of the things that ran through my mind were things that we've certainly talked a lot about today, one of which is stigma. Stigma around the patient, and this being some kind of choice, stigma around the disease itself, being a moral failure, certainly around the treatment. So we've talked a lot about access to treatment issues being related to stigma and perpetuated myths about treatment itself. So we are trying to do a lot of work at our institution on instituting curricula to really avoid perpetuated use of stigmatizing language when we're training students, residents, fellows throughout the entire healthcare system. And so this is a primer that all of our students get loaded the first day on their curricular management software on stigmatizing terminology and alternative words that they can use in the clinical setting. And you'll notice one of them there, and shout out to Maya, is medication-assisted treatment as being one of our stigmatized terms. And we still use MAT, not CAT, and say medications for addiction treatment. But nonetheless, something that we feel very passionate about from day one when our students walk onto campus is to really address this stigma head-on. One of the challenges here about that, about avoiding stigmatizing language, is then also doing faculty development around this, because we can train the students as much as possible, but if they get out into clinical rotations and other folks are modeling stigmatizing language, we really lose what they've been taught. And in thinking about my friend who didn't have access to care, I also thought, gosh, did he interface with anyone in the medical community? And maybe was he just with a provider who didn't know what to do with this or who didn't even ask? And so thinking about that, we really have noticed, certainly at our institution and in some of the work that we've been doing more nationwide, that curricular instruction around addiction is not required in medical training. Certainly not for medical schools, and I'm finding also not in the nursing schools. There are bits and pieces throughout a lot of curricula, and we've just completed mapping of our entire 4-year curriculum at Yale, looking for areas where addiction's being taught. And it's really kind of piecemeal. There's no particular course on it. And when we ask the students, even though there is some content there, when we ask the students, they don't even know they're learning it. So it's not being marketed to them as useful information to really address this issue. And I was talking with Maya at lunch that, you know, a lot of the students that we're interfacing with are very socially justice-minded and really look at the opioid epidemic as their problem to fix, and they're eager to fix it. So we really need to do a good job in training to give them the information in an accessible way. So thinking about medical training as an example of health professions training, there's really different levels of areas of intervention from a curricular standpoint. So there's the undergraduate medical education in the medical school, and I mentioned some of the work that we've done there. There's graduate medical education, which includes residency training and fellowship training, more advanced training. And then continuing medical education for providers in practice. And I'm just going to go through some examples of what we've done in these areas and then focus a little bit on fellowship training or more advanced training. So I mentioned that we mapped our curriculum at Yale Medical School, and this was in response to a 2016 plea from the Obama administration to have all medical schools sign a pledge that they would include content on safe opioid prescribing. And for a lot of medical schools, the pledge ended with a signature, and Yale decided to not sign on to the pledge, actually, but looked at it as an opportunity to really look at their curriculum. And we created a committee to develop a thread of addiction content throughout our entire medical training. And we're now working with our other health profession schools to do this. In terms of residency training, residents really thrive off clinical experiences, and that's how they learn information the best. And so one of the interventions that we've created within our residency clinic is all residents, when they come into residency training, are buprenorphine trained during their orientation. And then in each of the 3 years, they spend 4 weeks in a specialty clinic that's embedded within their own primary care practice, where they're practicing addiction medicine, primarily treating patients with opioid use disorder. And this clinic really serves a dual mission to educate learners and provide a service to our patients in our primary care practice. And then thinking about advanced training, there's been sort of a trajectory of the way providers can get advanced training in addiction over the years. So back in the 1980s, the American Society of Addiction Medicine had a certification exam. In the 1990s, the American Board of Psychiatry and Neurology recognized addiction psychiatry as its own entity, and there are 49 addiction psychiatry fellowship programs. But really, with the recognition that there were a lot more patients to treat, the American Board of Addiction Medicine really took on training as a big focus and started really promoting fellowship training in addiction medicine to complement what was already there with addiction psychiatry. And the Addiction Medicine Foundation has been really promoting fellowship training programs with the creation of the American Board of Preventative Medicine Addiction Medicine subspecialty just last year. We have 55 addiction medicine fellowships throughout the country now, out of 160 medical schools. We're now ACGME, recognized under the ACGME umbrella. And in terms of CME, training providers in opioid agonist treatment has been something that we've talked a little bit about, and there's opportunities that exist from treatment expansion and creation of local champions, but it's already been alluded to that we really need to think about the training model as well as the patient limits as potential barriers. And so in terms of my thoughts on things that the committee could think about in terms of addressing is really looking at destigmatizing treatment, destigmatizing some of the perpetuated myths through training, and enhancing provider education through community partnerships, empowering institutions to really have addiction medicine training be part of their curricula, and supporting educational research and dissemination. Thank you.